So, for those of you who were not in the room before, my name is Manfred Diehl, and I serve as the Interim Associate Dean for Research and Graduate Programs. It's now time for our 7th annual College of Health and Human Sciences Research Day lightning talks. And I was thinking, why do they call it lightning talks? And it dawned on me, by the end of each talk, the speaker's pants will be on fire. That must be it. I hope many of you were able to see the amazing breadth and depth of research and creative scholarship on display at this morning's poster session. Those who were there experienced work from all 8 of the college's academic units. For this next part of today's program, we invited one faculty member from each of our college's 8 academic units, along with the 2 PhD students in the college who were named as Dean's Fellows this year, to share their scholarship with the community. Excuse me. Each lightning talk will be a brief overview of that person's research, including innovation, integration, and impact. We call them lightning talks. Oh, now there is an explanation here. Because each person will have only 4 minutes, just kidding, but the 4 minutes are real, to share their topic, followed by a 3-minute question and answer period. And then the pants will be on fire. This year, we not only have the countdown clock ticking away, and that's down here, you can't see that. We've challenged our presenters by asking for one static slide without any animations. But we also supported them with a workshop on research storytelling earlier this spring, hosted by today's keynote speaker, Dr. Amy Pugh-Bernard, who you just listened to. Let's see how they apply these concepts to their research and creativity. I encourage you to engage with questions. Volunteers will circulate microphones for audience participation. Okay, is everyone ready for some lightning talks? Then let's go. I'd like to welcome our first speaker, Dr. Rodolfo Valdes Vasquez, from the Department of Construction Management. Okay.
Thank you. Well, good afternoon, everybody. Definitely these slides are too bright for me. So thank you for being here today. I just want to say that the expectations are pretty high in this moment, but we can do it, right? So I want you to close your eyes if you can at this moment and take a minute and think about when you were in college, maybe a long time ago, maybe a few years ago. For some reason, one of your faculty members ask you a question about what your future might look like, and maybe if you want to be a teacher in the future. Hopefully, you're thinking about that mentor, that professor. That happened to me a long time ago. And the reason I am here today is because that moment, that faculty member asked that question if I would like to be a teacher or I would be an instructor for a lab. So here's my slide, no animations at all. So if you have your eye open, you can see the slides. There is 3 main topics there that look at innovation, integration, and impact. Definitely there is not much time to cover all of those bullet points, but I want to mention a couple things that currently I am doing related to those 3 bullet points. The first one is about working with people, especially in the industry, to develop modules, teaching modules for them instead of for institutions. Has been a project that been really rewarding for me right now. There is 3 main companies that are being supported, providing feedback about how can we improve some of the internal process in their companies. So it's really practical research more than the theory that sometimes we see in some other programs. The goal was not only to support these companies, but also use them as a test base for creating more scalable teaching modules for other companies across the nation. The second bullet point that you see there is about something that has been exciting for me, especially at the beginning of the pandemic when we were not able to be working with our colleagues. I found this community of practice across the nation and have been working with them for the last 5-6 years. Some of these faculty members are from different institutions across the nation, and some of them internationally, actually. So at different levels, Research One, more teaching-focused institution. And the main thing that we do in that community practice is to support faculty members how to teach sustainable infrastructure projects in their classes. So that has been really rewarding for me, and also been the potential to create some teaching modules in that space. The last bullet point that you see there is about the impact I have been doing through my career, not only teaching classes, but also developing teaching modules for others so they can use those teaching modules in their own classes. I added the picture of my study abroad program. That's a study abroad program that has been a collaboration with institutions in Costa Rica and with colleagues here at CSU, and has been really rewarding to see how has been used as a module for other study abroad programs, and we have got an award from the design of the curriculum. So what is the story here, since my minutes is going down here?
Well, actually, your minutes are already up.
It's already up, so there is only one question, I guess. What I want to say, the final message here is that you never know what you can do when you're a faculty member and how impact people's life. That faculty member that asked that question to me about if I want to become a teacher, create that ignition about how to develop multiple teaching modules, not only in one institution, but across the nation and internationally. So thank you so much.
Stay here, stay here. Now we need lightning fast questions.
I'm just curious what kind of platforms you use. Yeah, what kind of platforms you use for your training modules, and how you do that like outside of campus is hard to share. How do you develop websites and things like that?
Yeah, so for the community of practice city, normally we use a Canvas platform that we can share across different institutions, so it's open access. And also we have PDF, we have the PowerPoint presentations for all the modules. For conference papers, for instance, most of the conference papers are easy access, and if you reach out to me, I will be happy to share. Yes. One more minute.
We have 1 more minute left. 1 minute and 10 seconds. No questions?
No questions. Can I say something then?
Yeah.
Can I give some in my minute, right? Well, I just really want to invite you to think about your students. I know we have probably some graduate students here too, so you also are mentors. So think about those undergrad students and how can you support them. Again, I felt like sometimes the impact we have is through those students that graduate and are doing a great job in the industry. So just keep that in mind.
Thank you very much. Okay. Our next speaker is Dr. Paula Alaszkiewicz. Avenir Endowed Curator of the Avenir Museum Design and of the Museum of Design and Merchandising, and Assistant Professor in the Department of Design and Merchandise. Did I pronounce your name correctly?
Beautifully.
Yeah?
Yes, very beautifully. Thank you.
Yeah, great. Okay, so let me explain.
Okay.
This works. It counts down.
Okay.
And when it gets to 3 minutes, because those are the
Hopefully, and the slide will come automatically.
yeah, it's right there.
Okay,
Okay?
perfect. Thank you. Good afternoon. Today I am discussing pockets. Yes, the humble, relatable quotidian pocket, which, despite its apparent simplicity, is a portal to a complex, powerful, and ever-relevant history. This became apparent to me as I developed the exhibition, Thanks, It Has Pockets, on view at the Avenir Museum for 4 more days, so please head over there this week. The genesis of this exhibition was a singular garment in the museum collection, this lilac-colored mohair coat from the 1930s, with large decorative, yet functional, teardrop-shaped patch pockets. This coat inspired a closer look at the pockets hiding in our collection. From an initial review of approximately 120 garments, a refined selection of 45 garments and accessories from the 1790s to the present were organized in 11 themes. Taken as a whole, the themes represent a hypothetical spectrum from function to fashion on which pockets can be situated. For example, this 9 by 20 inch pocket on a hunting jacket, intended to store a bird during a hunt, aligns more with function, while the fake pockets on an exquisitely tailored coat reflect the preoccupations of fashion. The way the curatorial process built out from the garments advances methods of material culture studies, in which individual artifacts inform theme development and guide secondary research and the application of broader theoretical perspectives in an inductive process. Engagement with primary sources and literature revealed the extent to which pockets, or the lack thereof, are linked to complex issues such as property ownership, access to public space, political privilege, and a binary system of gendered clothing. This is evident in the pockets experienced by most women in early modern Europe and America, which were separate, detachable, tie-on pockets. These were worn under one or multiple layers of skirts, secured to the waist, and accessed through slits in the outer gown. With their proximity to the body, tie-on pockets offered privacy and facilitated possession under a legal framework that prohibited married women from owning property, including personal effects. In the early 20th century, pockets became a metaphor for women's right to vote. An American suffragist referred to pockets not as a question of fashion, but rather as a question of morals. Members of the suffrage movement might have something to say about the state of women's pockets today, because despite the proliferation of pockets in both men's and women's wear over the 20th century, pockets on women's garments remain less common and smaller. A 2018 study found that an iPhone 10 could fit in 100% of the front pockets on men's jeans and only 40% of the same pockets on women's jeans. As I'm sure many in the audience know all too well, pockets in women's clothing are routinely sewn shut, or worse, fake. Infuriating, I know. But this is the power of the pocket. It provokes anger and frustration when denied, and joy and empowerment when present. Our common daily experiences with pockets are what make them so relatable and therefore productive as an exhibition topic. As my brief presentation has demonstrated, the humble and quotidian pocket is a portal to a powerful and ever-relevant history. I am very proud to share that since mid-September, over 2,000 visitors to the museum have engaged with this important history and have experienced the power of the pocket. Thank you.
Any questions? Lightning fast questions?
Hi, I just want to encourage everybody to go see this exhibit. They have fantastic exhibits all the time. This one is so thought-provoking. I don't actually have a question, but I want to tie to our previous speaker who just encouraged us, empowered us to really think about working with students. And I will say I had the privilege to hear student presentations on pockets and to learn fascinating details about what was found in some of the pockets that they explored in putting this exhibit together. So little circle of connection, but really great exhibit. And I've been thinking about pockets ever since last fall.
Thank you. Thank you.
Out of surveying all the pockets that you saw, which pockets should make a comeback in today's fashion?
Well, great question. Thank you. I think the pockets that have made a comeback are the Y2K cargo pants that have pockets everywhere. So we actually bought a pair of vintage Y2K pockets that I could see my students wearing, that have a combined storage of over 300 square inches, I believe, of pockets across 11 pockets. So those have made a comeback.
There was another person.
I don't have a question. I just wanted to say I can totally relate with not having the pockets. I don't have a single one in my outfit today, and I can totally relate to it. So thank you, and it's a really important job. So thank you so much for entertaining us.
Thank you. Yes, I think we all know this feeling of having no pockets or they're sewn shut.
I just had it today morning, so I can totally say it.
Yes.
Thank you.
And maybe I can share a story.
Sure.
I thought this weekend I had lost a really cherished item. And then I realized I actually wore a pair of pants on Friday when I had an x-ray taken and had to take it off the necklace.
Yes.
And I went back to the pants, and in the pocket was my cherished necklace. So.
Yes, I'm happy for you. Well, thank you. Thank you all so much. And yes, please come over to the museum. We are open 11 to 5 and 10 to 4 on Saturday. We'll see you there.
Thank you so much. Thank you, Dr. Alaszkiewicz. Our next person is Dr. Sarah Stotz from the Department of Food Science and Human Nutrition. No, that's... Well, Dr. Susana Muñoz? Okay, but that's not the order in which it is here in the script. Anyway, but you're welcome. You're welcome. I never want to stop an eager faculty member.
Appreciate you. Thank you. Okay,
Maybe I should look at the screen.
you're good.
Okay, so the way it works is it will count down. When it's at 3, then that basically means you're 4 minutes.
Okay, thank you. I am an immigrant. I was 6 years old when I boarded a plane from Yucatan, Mexico. I didn't understand where I was going, but I arrived at a different language, different food, different sense of home. By the time I was 10, I was a naturalized citizen. The term naturalized was something I was not comfortable with, implying that I was somehow unnatural just because of my country of origin. But I digress. My path was not typical, but I carry that knowledge and my citizenship privilege into every dimension of my research. I'm here to talk about undocumented and DACA college students, specifically to ask a question: why do our colleges and universities continue to fail these students? Over Over 427,000 undocumented students are currently enrolled in our colleges and universities. The majority of them are Latinx. They are long-term residents of this country who have completed the majority of their schooling in the US. And by that definition, they are our students. And yet they have navigated higher education under conditions of fear, exclusion, and institutional neglect that their peers with citizenship privilege sometimes never face. We are tempted to call this a failure of our policies and divisive politics, but I want to offer a different framing. Our immigration system isn't broken. It's a system that is built on white supremacy. Let me explain. From the Chinese Exclusionary Act of 1882 to the Mexican repatriations of the 1930s, where mostly US citizens were mostly rounded up as scapegoats for the Great Depression, to the criminalization of undocumented immigrants today, our laws have always used legality as a proxy for social and racial exclusion. It's always been about deciding whose presence on this land is legitimate, whose labor is extractable, and whose humanity is conditional. Higher education and other systems were built on that same logic, a logic we've never fully reckoned with. So what does this mean for us at CSU? It means that students may take 8 years to finish a 4-year degree, not because of lack of ability, but because they're paying out-of-state tuition, working multiple jobs, unable to tap into the federal financial aid, and navigating every policy barrier without adequate support. Students who walk into a resources office to find them understaffed, students who sit at a dinner table with their families as they rehearse and plan what happens if their parents get deported. My research names what institutions do in response: performative equity, statements of solidarity, diversity committees, undocu-friendly designations. But as one particular student in my study put it, the institutional statements about racism became too many of the same message. Words without institutional and structural change are just rhetoric. I've also developed a framework called undocu-servingness that gives institutions and faculty a set of concrete commitments to work towards. They include racial and legal consciousness, addressing labor inequities for the staff to do this work, linguistic validation, flexible courses, and a genuine co-governance that includes students and community. So what does this ask of us as faculty? First, develop what I call a racial legal consciousness. Understand that undocumented students are not navigating the same contexts as their peers. Understand that there's a degree of fear that is present in our classrooms, whether we name it or not. Second, call out racial injustices. Push back on them. Remember that naming is also not enough without institutional accountability. The history of anti-immigration is long, and the harm is structural. Students need faculty who will use their institutional voice loudly, collectively, to demand something better. As parting words, what we have witnessed, the ICE violence, the unlawful deportations, is a testing ground for our broader civil rights. Democracy will not fix itself. It only survives when we refuse to let these injustices become normal, only when we keep speaking, keep resisting, and keep showing up. To the immigrants in this room and not in this room, know that you matter, not just because of the brilliance that you bring to our institution, but because being an immigrant is part of our full humanity. I am an immigrant, and I stand with and for undocumented students and their families. Please join me.
Okay, again, lightning fast questions. Yeah, Michelle?
At what point, where do we handle our attack, the anti-immigration attitude? I know that in in my child's classroom, they weren't necessarily allowed to teach it, but she is reading about stories of immigrants and how they come to America to set up a wonderful life. If they miss that point in their education, how then do we tap into educating people of the importance of understanding struggles of others?
I mean, when you think about it, I think what we need to understand that this country was not founded, right? We didn't discover America, right? There was already original stewards of this land. And I think the more that we understand sort of like who we've sort of excluded and who is sort of the desirable and undesirable for, that is sort of entrenched in our society now. I think that we understand that as kids feel it, right? And I remember like bringing, beans and my home food to class, and it was like, oh my gosh, nobody wanted to sit with me, right? And so I know that continues to be a recurring story in our school system, right? And so it's really important to have community and teachers and parents that are really in solidarity with valuing that asset. The lived immigrant experience is an asset, for our kids. So that's sort of how I put it. Yeah, thank you.
Thank you very much, Dr. Muñoz. Okay. Let's see who is next. Before I make another mistake here. Now we're back. So next up is Dr. Sarah Stotz from the Department of Food Science and Human Nutrition.
Okay, so that's going to count down.
It counts down.
Okay.
And when it's at 3, that means
Then I'm
your
done.
4 minutes are up.
Got it.
But, by now, I think
I got
we
the
have gone
gist.
over a little bit.
Okay. Okay, well, thank you. All right, well, as a dietitian and diabetes educator, I've heard the same question hundreds of times. What can I eat? People with type 2 diabetes or any nutrition-related chronic disease are often overwhelmed from the nutrition education they receive from their family, their favorite social media influencer, or ChatGPT. Some of us dietitians are very well trained in one-on-one counseling. That's kind of our comfort zone. But we also know that group-based learning can be incredibly effective for adults managing chronic disease. It creates connection, shared experience, and collective problem solving. And yet, nutrition educators are often expected to implement evidence-based diabetes curricula that were never designed for the specific communities they serve. For those working in American Indian and Alaska Native communities, education materials often overlook Native strengths, traditional foods, and culturally important holistic health framing. So educators end up adapting in real time, revising slides, changing examples, reworking lesson activities, often without the time, the space, or the structured support to do it well. That gap between the question patients are asking and what educators are equipped to deliver is where this work began. What Can I Eat is a diabetes nutrition education curriculum that my team originally developed in 2019 and is now endorsed and distributed by the American Diabetes Association. The facilitator and participant guides are displayed on the slide. What Can I Eat Train the Trainer workshops are specifically designed for educators serving Native communities. This 2-day interactive workshop focuses on hands-on learning, facilitation practice, and peer exchange of ideas. There's no cost to participate, and continuing education units are offered. With that context, I want to highlight 3 things. When I talk about the innovation of this work, I want to be really clear that it's not about a new, novel nutrition education message. The innovation is grounded in our community-based participatory approach, which means starting with showing up, listening, and offering something of value before asking for data or research partnership. The Train the Trainer model is intentionally designed as an offering to community, and that distinction matters, especially in Native contexts where extractive research has caused real harm. Innovation here also means investing time for my research team to be physically present in community, and time to build meeting relationships and trust while we are there. As a land-grant institution, CSU carries a responsibility to tribal nations, and that responsibility cannot be symbolic. It has to be operationalized into tangible, sustained, reciprocal ways. This program is one way I attempt to translate that responsibility into practice. Through my long-standing partnerships with tribal health programs, urban Indian organizations, Indian Health Service, and my beloved Native colleagues, this work moves beyond outreach towards sustained engagement and shared priorities. This work aligns deeply with the CHH mission around equity, community engagement, and translational scholarship. At its core, What Can I Eat sits at the intersection of research, training, and practice. We're not just generating evidence, we're actively translating it into real-world settings where diabetes care happens. In terms of impact, as you can see on the slide from the map and the group photos, our training has now reached over 300 educators across multiple states, and we have more trainings planned in 2026, and I have the privilege of bringing my graduate students to some of these trainings with me. But the most important impact is not the number of people we've trained, it's that these educators are now better equipped to deliver culturally relevant diabetes nutrition education in places that are often under-resourced to provide the optimal diabetes care that these communities deserve. By strengthening the workforce rather than creating a one-off intervention, we're expanding access to diabetes self-management education in a way that's sustainable, scalable, and locally owned.
And again, lightning fast questions. Yeah, we have some here.
I was wondering if you look at the impact of food deserts that are really common in these communities and how you address those.
Yeah, sorry, with the light, were you straight in front? I just wanted to make eye contact, so yeah. I'm trying to. Yes, so the work that this particular education curriculum, there are parts and pieces of it that are adaptable for each educator. We don't want to make the we don't want to make the racist assumption that just because you're Native, you live in a food desert or have trouble accessing food. These folks all are Native and have diabetes. That's the commonality. So there are some parts of the lessons so that if the educator realizes, I am working in an under-resourced area, I am serving a community with this particular series of classes, that they do have a long ways to go to the grocery store, then they can adapt the curriculum with some kind of, this isn't a word, but I use it a lot, swap-outable lessons that would accommodate the fact that some folks live in spaces where it's really challenging to get healthful food. That's a great question. Thank you.
Could you elaborate a little bit more on the demographics of the people participating in the Train the Trainer workshops? What type of healthcare professionals are in there, and what healthcare professionals do we need to see more in these workshops?
Yeah, thank you. That's an awesome question. So I'm a dietitian. It originally was developed, the curriculum we developed for peer and community educators. So it really wasn't supposed to be healthcare professional deliver option because largely in a lot of these communities they lack regular access to a dietitian. We didn't want that to be a bottleneck. However, for continuing education credits to come to our training, registered dietitians, registered nurses, pharmacists, certified diabetes educator and support specialists, so those 4 folks, and then community health workers all get continuing education credits. But we have folks that come to the training that, we have tobacco cessation specialists, we have all kinds of ancillary health-related community members, because they can also be the hype person for the class. They might never be the person to actually teach the class, but in community, they might have a lot of connections, and then they can talk about the class in a little bit more of a lived experience because they came to our training. So we have quite a bit of diversity, but to answer your question about who we're not getting in the classes, I think we don't have that many physicians, but they're kind of busy, and that's okay. I don't think we're waiting for the physicians to join. Thanks for that question. Sorry if you're a physician in the room.
I actually have a question.
Sure.
So to get entry into communities, do you use specific gatekeepers that are culturally relevant in that particular context?
Yeah, that's a great question. So the question was how am I getting in these communities to even offer this, I think. And so I'm a non-Native person, but I did have the privilege of being the study coordinator for Native physician scientists for many years down at Anschutz Medical Campus. She is nationally
widely known, beloved in a lot of Native communities, and had a lot of leadership roles across Indian Health Service, tribal health service organizations. And so I was definitely known as like Dr. Moore's worker for many, many years. And that actually is probably what offered me the most entree into a lot of the communities. And then also just making sure that I work really hard to support myself with a lot of Native collaborators. And so instead of having maybe, you know, a co-investigator who's a methods person or a scientist or a stats person, I have co-investigators who are Native people who live in their community. And that certainly helps.
Are there any more questions? Well, thank you so much, Dr. Stotz. Excuse me. So our next speaker is Dr. Lyndsey DuBose from the Department of Health and Exercise Science.
Thank you so much. I just want to say I was so jazzed about the presentation about pockets. I do not have pockets in this dress, but it's the most fun thing to be like, but it has pockets. My name is Lyndsey DuBose. I am a newish professor in HES. I'm also the director of the Brain and Vascular Health Lab, which we call the BRAVE Lab. Our lab primarily focuses on studying heart and brain health in people, but what I really care about as a research passion is to study whether the presence of female reproductive disorders affects heart and brain aging in women across their lifespan. One of the disorders that we're currently focused on is called endometriosis. Endometriosis is a chronic pain condition that affects the entire body, not just the reproductive disorder or reproductive system. Endometriosis occurs when uterine-like tissue starts to implant on structures in the abdomen that is not the reproductive system, and these can include things like the bowels, the bladder, the stomach, the kidneys, and the rectum. Symptoms of endometriosis are diverse. They can be different in one person versus another. This can include things like chronic pelvic pain, painful menstruation, pain in between periods, digestive issues, anxiety, fatigue, brain fog, and many more. While endometriosis is relatively common, it affects about 10% of people with a uterus. This is probably an underrepresentation because on average it takes about 7 years for people to get diagnosed with endometriosis. So I want everybody, I see a couple of head nods, but I want everybody to stop and pause for a second of what it must feel like to be living with a chronic pain condition for 7 years and to not have a diagnosis or know what is wrong with you. Additionally, a couple other numbers that I think are important when we think about endometriosis is that it receives less than 0.1% of grant funding from the NIH. So 10% of the population, 0.1% of funding from the NIH. And while I try really hard not to do math in public as a physiologist, in fact, I have a rule against it, I think the other important thing to really realize is that for every $4 that is dedicated to endometriosis research, about $150 is dedicated to Crohn's research, which is another chronic inflammation condition, but Crohn's affects about half the number of people that have endometriosis. So, like I said, I try not to do math in public, and I've thrown a lot of numbers at you, which is like I've already defied all of my rules, but I hope that you can appreciate that there's a lot of gaps in clinical care for providers that help to see patients here, but also for people who live with this disorder. Recent studies show that people who have endometriosis have an increased risk for the development of heart disease and stroke. We don't really know why this is, in part because there's limitations in the research, but we think that chronic elevations in inflammation that affect the entire body are involved. Importantly, the presence of risk factors for heart disease and inflammation increase and affect brain health over long periods of time. We don't know if brain health looks different in people with endometriosis, but we do know that people with endometriosis are more likely to have things like brain fog, anxiety, fatigue, and other disorders of the brain. So our group right now is really trying to understand, do people with endometriosis have differences in heart and brain health? What are those and why might they occur? Our hope is that if we can understand why this happens, we can design interventions that help to improve not only the quality of life in the short term for patients with these disorders, but also we can improve their health span across their lifespan. Our other hope is to help to understand whether treatments that are used to manage symptoms of endometriosis impact heart and brain health. Endometriosis has an average age of diagnosis of 27 years of age, and people tend to live with this condition until they go through menopause, which has an average age of 51. Again, I'm doing math in public, I don't want to do it. But what's important is that this means that they're using medications that affect hormones or hormonal contraceptives to manage their symptoms for many decades. And so our group really wants to understand whether the use of certain medications versus others to manage symptoms may have better or worse effects on heart and brain health over time. In summary, our innovation aligns with the college, and I'm trying to see my notes. This project advances the health and representation of people with endometriosis in research, an underrepresented but common disorder. More importantly, we hope to have a direct impact on clinical care in the future, but in the short term to help people who have this disorder to know that they're seen and that we're fighting for them. And I'm happy to take any questions with the remainder of my time.
Oh gosh, I got the microphone. I was wondering if your lab is doing any research looking at the difference in activity levels of folks with endometriosis versus not, because we also have really strong evidence that exercise and activity levels affect heart and brain health as people age.
Yeah, currently we're just piloting work. It's something we want to do in the future. What I can tell you is there's some weak evidence that people who have endometriosis and exercise, that they may have better blood vessel function, which is related to heart health. We don't know necessarily related to the brain. I also think this is a really important connection with severity of symptoms. People who have more severe symptoms or their medications are not managing their symptoms as well, they're less likely to be active, and we're seeing that anecdotally in the population. So I think it's important. We're just not necessarily currently looking at it in our pilot study.
2 questions. Is it a linear relationship between severity of endometriosis and heart disease going up?
No. The hard part, the simple answer is no, and I think it gets a little bit complicated. So the other confounding factor here is that the severity of endometriosis is not correlated or related to how much endometriosis somebody has. It probably is more dependent on where that endometriosis is and where nerves are. The pain also, and how people perceive pain also differs. That's probably also an important part of the connection, but nobody's looked at that.
Mm-hmm. And then also the connection to heart disease. How much do you think it relies on stress? I know lots of females who have this, and it is stressful and painful versus the actual inflammatory factor of the disease.
Yeah, we're trying to look at that right now. So we're trying to characterize the physiology. We're also trying to characterize the lived experience in patients to try to better look at and disentangle these two things, whether it's survey-based or some of our objective measurements. Regardless, I think both of those things are probably involved. We also know that stress, inflammation, and unfortunately trauma are experienced at higher rates in people with endometriosis, do also drive up inflammation. So it may be the same, it may be additive. We're trying to figure that out. Thank you.
Our next speaker is Dr. Ana Gutierrez Colina from the Department of Human Development and Family Studies.
Thank you very much. Thank you, Dr. Diehl, and thank you so much to all of you for being here today. So most of us know what healthy habits look like, things like moving our bodies, getting enough sleep, or eating well. But if knowledge alone created change, we would all be doing those things consistently. The reality is that in daily life, especially on days that are stressful or unpredictable, even the best of intentions can fall apart. And that gap between knowing and doing is the challenge that my work tries to understand. Now, I'd like you all to think back to our College Wellness Challenge last semester. We had a great list of healthy habits to work on, and yet how many of us had trouble getting started or sticking with our goals? If that happened to you, like it happened to me, think about what was going on in your life at that time. Maybe you were not motivated on some days. Maybe you were tired on other days. Or maybe you just had too many assignments. Everyday life is messy, it's not static, and it definitely does not happen under ideal conditions. And it is those day-to-day realities, what is happening within us and around us, that can make it hard to turn knowledge into action. So my research starts with this simple question. What is actually happening in people's daily lives when health behavior, like physical activity, succeeds or doesn't? Now, to do this, we use innovative technologies like wearable sensors and smartphones to capture real-time data in the real world. And these tools allow us to be able to capture how moment-to-moment changes in people's internal states, like their energy or the stress level or motivation, interact with the environment to shape behavior. We also look beyond simple averages, like how someone's average level of motivation relates to physical activity. If you're musically inclined, you can think of an average as a single pitch, but real life is more like a melody, right? Our emotions, our energy, our motivation go up and down throughout the day, and it turns out that some of those shifts really matter. Some of our data, for example, has shown that among adolescents, when they experience more stress than their typical level on a certain day, they tend to be less physically active that particular day. So we really want to understand each person's behavioral melody and how those patterns shape health. Now, technology alone is not enough to improve health, and that's why part of the work that we do is also building partnerships with communities and with other disciplines to try to understand these questions. And that is something that is closely aligned with the mission of our college. So that means that a lot of the questions we ask and the protocols we design, the intervention strategies that we hope to develop are created in partnership with youth and families. And it is really that collaboration that allows us to make our science relevant in the real world. So ultimately, our goal is to impact human health. And once we begin to understand how health behavior, like physical activity, plays out in the context where people actually live, we can begin to move beyond one-size-fits-all advice to develop more personalized interventions that are timely and that provide the right kind of support when they're likely to make the biggest difference. And that is one way that we can begin to bridge that gap between knowing and doing. So I'd like to leave you with 3 main ideas from today's lightning talk that I hope you remember. The first one is that health behavior does not happen in a vacuum. Context really matters. The second one is that real-time data can allow us to start to understand what are the barriers and facilitators that can support physical activity in the real world. And that information can really shape the kinds of personalized and timely interventions that we develop. And the last one is that the most effective interventions need to be developed in partnership with communities. So with that, I'll be happy to take any questions. Yes.
I'm curious how you're factoring social determinants of health into your research and how you're factoring that into individuals' contexts when you're trying to apply health behavior interventions and changes.
I think that's a really important question, why we know that social determinants of health can be powerful drivers of health behavior. So considering those as important, in some of the questions and protocols that we develop, we ask about things like whether they had access to social support or access to certain spaces. I think it's important to consider those, especially in the development of interventions. And some of the focus groups that we we hope to do with youth and families, those are certainly questions that will be part of the conversation. I think that we're one variable. They're not, determinants of the health behavior that people as individuals can engage in, but they certainly will shape the types of interventions and strategies that we provide to families to support that behavior change.
Could you describe a little bit more of what the smartphones and wearables are measuring? I know the basics are respiration rate and heart rate. What else are you looking at?
So we're primarily measuring physical activity, so things like step counts, moderate to vigorous physical activity, sedentary time. And then the smartphones, we have used a protocol, it's a 7-day protocol where teens get pinged 3 times a day, morning, after school, and right before bedtime. And we ask them questions at each one of those occasions about how they're feeling, who have they spent time with, what is their stress level at that moment, did they make a plan to be physically active that day? So those are some of the variables that we're assessing with those smartphone devices.
What is your favorite or preferred device?
My
monitoring?
favorite device?
Especially if they're commercially available.
Well, we really use actigraphs as like the wearable that we use. I think, it's a scientifically, backed device. We know that it provides reliable data. They're a little bit clunky, right? So they're a little bit bigger. Sometimes teens don't love to wear it. So I think for a future project, I'd love to use some other device that is a little bit more, maybe fashionable and cooler for teens to wear. Yeah. Thank you all.
So our next speaker from the Department of Occupational Therapy is Dr. Janell Pisegna. Yeah. So the groupies.
Hello. Thanks for having me today. I promise that the agribility faculty did not co-conspire on the things and the metaphors that we used in our presentations. I can build on some of what Dr. Gutierrez, Colina talked about with using bridges to change behavior. It's a great segue. Thank you for sharing that. So my research has nothing to do with frogs, and yet everything to do with a specific frog. Was a nickname of a person I encountered early on in my clinical training. So I am an occupational therapist by background, which means I'm an expert in the stuff that occupies our time. And I encountered this person nicknamed Frog, who I didn't know at the time, but would eventually embody kind of the intersection of the common threads within my research. So Frog had experienced a pretty significant stroke, and so moving both the right side of his body was really challenging. And I was practicing and lived in a pretty rural location, and so there weren't a ton of super intensive medical resources for neurorehabilitation. Or kind of local community hospital where I worked was it. And I encountered Frog and kind of brought things together where I felt like I had all these tools in my toolbox of how I could help this person recover from this stroke. But it didn't matter if he was so depressed he can't even get out of bed. And so I tried to be a good evidence practitioner and went to the literature to find resources on what do I do for these folks? As an OT, how do I address mental health in someone that's maybe had a stroke or a brain injury? And I couldn't really find much. And so I thought, wow, if I feel this way, other folks maybe do too. And that allowed me to use my OT toolbox and pair it with a PhD in research training to open up a whole new toolbox to help me kind of live this sort of innovation idea, which is from the quadruple aim in healthcare, that care of the patient requires care of the provider. And so the theme of my work is I like to help folks in rural places, and practitioners there, healthcare providers there, address mental health in folks that have neurological diagnoses. And my goal is that I want to help the community by helping the people that serve that community, in particular, people with disabilities. So I like to study the healthcare provider behavior change or community worker behavior change, and giving folks tools in their toolbox using implementation science, the study of why behavior change interventions work or don't with community workers, healthcare providers. And so these are some of the strategies we've used across our different areas within neuromental health and community rehabilitation, with the Collar Agribility Project and our Office of Engagement and Extension, and work we've done and hope to continue to do by not just training, but using these evidence-based behavior change strategies of that many folks have talked about using and maybe just didn't name them, right? Engaging community, tailoring interventions to the context, and co-designing, co-developing things together is a really effective strategy that I myself try to use. And so I'll stop there and would love to take questions. And if you want to connect with me or any of the folks that I'm lucky enough to work with, that takes you to the directory website with my contact info. I talk with my hands. This is hard.
I'm going to use an OT speak model and actually change model. So some other departments should know about this too. So
okay, cool.
What part in trans-theoretical model of change do healthcare practitioners have a particularly trouble with when it comes to implementing evidence-based practice?
I feel like oftentimes it's a dichotomy. Either we are in pre-contemplation, whereas we aren't aware of what we could be doing, and then we come to a point where maybe we're aware of what we should be doing, but as a survival strategy, right, we're faced with 90% productivity standards where we're supposed to be spending 90% of a 10-hour day in direct patient billable time. It's a heavy job to walk with folks. It's a privilege, but it's heavy. So there's a significant amount of burnout in that care for oneself when you have to get up and do the same exact thing the next day. And we're not incentivized to engage in professional development oftentimes. So it's another thing we're doing on top of all the other things. So I think it's either folks don't have capacity to know what they could do or what their options are. And then when they know, they encounter a lot of system process barriers in particular that make it hard to do the thing. And then to know if they're doing it right or not. Yeah, which training is great, but training alone will not change healthcare provider behavior, unfortunately. And if you come to Knowledge Exchange, this is our theme for the OT department, is connecting evidence to practice and connecting practice to evidence.
Hi, Janell. Thanks. You ended by speaking about barriers, and I wondered if you might speak for a second about barriers in engaging with rural communities or providers, and maybe some of your strategies that you've found more useful?
Yeah, I think there are certainly challenges. Specialty care, right? It's harder when you're in a rural environment. You often have to be sort of that like jack of all trade, and so it's hard to when you're operating in a system where professional development maybe isn't incentivized. It's hard to develop one's toolbox. I think that's a unique challenge. I think accessing community care and the resources of health structures can also be a challenge. Having been at, really nice academic medical centers where they have grand rounds with physician scientists and other discipline scientists kind of on site to connect with, or using research in the moment, that culture becomes, very well established. And so other places that don't have that infrastructure, that can be challenging as well, and then continuity of care can be challenging across the continuum too, especially for rehab, where we tend to see folks in different stages. But there are facilitators too that I hope to explore at Knowledge Exchange. Yeah. Thank you. Yeah.
And we have one more faculty speaker, Dr. Brittanie Ash from the School of Social Work.
Oh, we weren't kidding about those lights. I feel like everyone made slides that were imperative to their talk, and mine is just a pretty picture. So, my name is Brittanie Ash. My pronouns are she and her, and my research centers on one urgent question. How do we create conditions where LGBTQ youth, particularly trans and non-binary youth, can experience belonging, health, joy in the midst of hostile political environments? I approach this work through community-engaged participatory research that spans schools and health systems and civic and policy contexts. And rather than studying LGBTQ communities from a distance, I tend to partner directly with young people and organizations to understand not only disparities, but the conditions that allow young people to thrive, mobilize, and to build power. Working with young people, I'm called to engage in research that lifts up their lived experience. And this was especially important when I partnered with an LGBTQ+ residential learning community in Texas, where students lived and learned together to examine how participation in this RLC shaped their identity development, their belonging, and their well-being. So rather than studying the students, we studied with them using youth participatory action research methods. So in that process, students co-designed research questions, helped us determine what well-being meant in their context. They selected creative forms of data collection, and one of the most innovative aspects of that project was using memes as qualitative data. Students created memes before and after their first year in that program to represent their experiences of navigating identity, campus life, and state-level anti-LGBTQ policies that were happening in Texas at that time. Those memes captured humor, resilience, fear, pride, political awareness in ways that the traditional interviews that we did not capture. Also, I integrate large-scale population data with community-driven work, using data sets like Healthy Kids Colorado and the Colorado Trans Health Survey. Me and my collaborators examine intersectional identity, so thinking about the intersection of gender identity and sexual orientation, or geography and sexual orientation, and other socio-demographic factors, and how those shape mental health and substance use and belonging. I've actually also had the pleasure of collaborating with CSU's geospatial centroid to think about how disparities may be related to political outcome data. And that allows us to identify communities that are in the greatest need of intervention, thinking about like behavioral health, but also in intervention and advocacy efforts across the state as well. In all the work we do, we center protective factors and action, getting at the now what. This work integrates directly into the mission. I can't see that, but since I'm the last one, I'm just gonna roll. Into the mission of CHHS. We consistently show that youth at marginalized intersections particularly queer and trans and non-binary youth, have differential outcomes. But we also show that contextual factors that foster resilience and belonging, for example, access to spaces where students can be themselves, just like the Pride Resource Center here at CSU, are essential for students. And that's why it's also really essential that we protect cultural resource centers at CSU and across the United States, because our research is clear that when students can be themselves, it can save their life. So working closely in partnership with community-based organizations really ensures that research can move beyond just like publication, but into practice. So we can translate our research into intervention while also ensuring that students are co-creators and co-researchers and co-agitators in the work that we do. Again, our research is clear. Students thrive in spaces that are made with them. And this is especially important in our anti-queer and trans political context. In my work, again, students continually express that when they are in spaces that foster increased belonging and that catalyze their peer networks, they're able to process LGBTQ+ legislation collectively rather than in isolation. The RLC project that I mentioned in Texas gained national visibility when it was covered by some news outlets last year. And that coverage really just highlighted how community partnership can foster resilience for LGBTQ students that are in these politically restrictive environments. And for me, that really underscored the public relevance of this work. It's not just abstract scholarship, it's about students' lived safety and their belonging. Thank you. Also, the CSU women's basketball team is fighting for the Mountain West Championship tonight at 7:30.
So we have about a minute and a half for some questions.
It can be about basketball as well.
I unfortunately don't have a basketball question. I was wondering, there are lots of us in the room that are training to be clinicians. What are some protective factors that you think clinicians could use to support trans youth that are in particularly precarious legal situations?
I mean, yeah, there are tons and tons of resources available for that. I think off the top of my head, there is a researcher out of Michigan State University. Their last name is Puckett, and they offer a ton of resources. They have a book about how to be an inclusive practitioner, specifically for trans and gender nonconforming and non-binary clients. So definitely check out, I think if you just Google clinician, inclusive, LGBT, or trans, and Puckett, you would get to that information. But yeah, like even understanding the WPATH standards of care specifically for folks that might be wanting to explore like gender transition and stuff like that, it's definitely up to clinicians to be up to date on language, policies, and there's tons of information out there. Thank you.
I was wondering if you could elaborate a little bit more in your qualitative work on teens' political awareness of LGBTQ rights. Is it more superficial of like what left versus right believe, or is it going down to legislator of like, oh, we really like this act? Can you describe what their knowledge is in that political awareness?
So this was specifically working with first-year college students, and they were hyper aware of what was going on because it was trickling down, much like where we saw this year happening. So, you know, it was trickling down from state level policy into the college level. So like that program that I worked with no longer exists anymore because of state level policy. And so they were definitely aware of what was going on. And we also, it was like a year-long program where we were doing advocacy as well. So like if students wanted to write to their legislators, they could. If they wanted to write to the governor, they could. And we would help facilitate that process. But yeah, they were absolutely aware of what was going on. I'm not sure if that answered your question though. Thank you.
I think it became apparent during these faculty presentations that faculty and students really study and try to understand people in real life environments. Context matters was mentioned numerous times here, that we try to understand real life behaviors, and that a common thread is also how to improve individuals, families, communities' lives. So that brings me now to the talks from our 2 Dean's Fellows, students who received the Dean's Fellowship last year. And our first Dean's Fellow is Anjali Tiwari from Health and Exercise Science.
Good afternoon, everyone. I would like to start with a negative thought to start with, and pardon me for that. Imagine waking up one day and finding that something as simple as moving your feet, which you have done your entire life, suddenly has to be relearned. Quite negative, as I said. Well, this is the reality of 12 million stroke survivors that leave their life with. Stroke is an acute medical event that causes a disruption between the brain and the blood. And this leads to substantial disability and poor independence. The key to the successful recovery after stroke depends on how well we can learn, or in other words, can the brain still learn? In clinical practice, we see that some individuals respond really well to the therapy, while others, despite receiving the same therapy, do not respond that great. Until today, we cannot confidently say who can recover or learn during the session and who cannot. And these uncertainties lead to inefficient treatment planning and increased healthcare cost. But most importantly, it affects the individual's recovery and their quality of life after stroke. To address this key question, my Dean Fellowship research aimed to understand the key predictors of motor learning during the session. To measure the motor learning during the session, we used a goal-directed task as shown in the top center of our slide. Here, individuals were asked to move their ankle with respect to the target on the screen, and we measured their performance error with respect to the target. We used this performance error to define the groups. As you can see on the top right corner, the individuals who responded well and showed reduction in their performance error across multiple trials were classified as learners, while those who did not show any improvement were classified as non-learners, noted with the blue dots. We then used an innovative machine learning technology to understand the key predictors that can help us to understand who can learn and cannot learn after stroke. We use the machine learning technology because it captures the complex and nonlinear relationship between the variables that a traditional statistical measure might fail to take in account. We introduced participants' characteristics such as their age, sex, education, past medical history, their stroke characteristics, for example, type of the stroke, site of the lesion, and extent of the lesion. We further introduced the cognitive function across multiple domains, their strength, balance, and functional capacity. We collectively introduced these predictors into a machine learning algorithm, and our results suggested that machine learning was able to correctly identify 80% of learners and non-learners. But most importantly, as you can see in the bottom right corner, episodic memory, executive function, and functional capacity were the top 3 predictors to identify the learner's status after stroke, followed by selective attention, strength, and education. Recall that my question was to understand the key predictors that can define the learning trajectory after stroke. Well, it turns out that patients who can perform and has an intact thinking and memory and can perform day-to-day activities on the daily basis tend to be the better learners compared to those who do not. Further, the usage of the machine learning can help us to give us the user-friendly tool that can be used by the clinicians and the scientists to understand the individual learning profile after the stroke. Further, that can be also used to refine the assessment and personalize the rehabilitation for the individuals after stroke, Ultimately, this work helps us to improve the overall functional recovery and quality of life. That would further weaves into the better well-being and community integration that closely aligns with our CHHS mission. Before I close, I would like to thank all my participants who volunteered their time in the study and the funding support through the NIH and the Dean Fellowship to make this work possible at Movement Neuroscience Rehabilitation Lab. Thank you so much.
And we take questions.
Well, a great question, actually. I would love to go for a more comprehensive task that can explain the learning aspect, but for the feasibility of this study, we chose a foot ankle exercise, which was also very strategized and good to understand the learning error that you can quantify more accurately across the multiple trials, and that could have given us more accurate version or maybe understanding of the learning status. I would not say this is the only way that you can learn the motor learning within the session. There are different ways, and the tool, depending on your research question of interest, we can choose the other task as well.
Thank you. Correct me if I'm wrong. It looks like the trials and the learning were within one session.
That's right.
Okay. Could you speak to the implications, if you think there are any, about motor learning over a longer period of time, right? Thinking about stroke recovery in an acute phase and then a chronic phase, and what your study maybe means for learning over the long term.
Absolutely. It's a great question, and I think it was one of my reviewer who reviewed this paper asked me the same question. So thank you so much. That helps me to prepare better. So the question was, a single session, how can it help you in the longer term? My short answer would be, I'm not so sure, but I can totally tell you with the surety that at least this single session of understanding can help us to identify who has more potential to learn during the session, but in order to understand the long-term motor learning, we will have to use a different paradigm that can be done over multiple practice trials and understand what the long-term impact going to be. That's a traditional motor learning paradigm that I'm talking about. But at least from this, we can at least understand after stroke or individuals with stroke, what are the capacity they can come to the rehab center, and what are the predictors that can help us to understand, at least in the initial phase, that the person can learn or not. And if they cannot learn, then definitely we can help them more precisely towards their assessment and rehabilitation, frame it well according to their need, and maybe maximize their recovery potential going forth. So if that answers your question. Welcome. I get it. Okay. Hi.
Thank you. This is a great presentation. Thank you.
Thank you so much. Yes.
Just wondering if you saw any significant differences between which type of stroke and the learners.
Absolutely. So as I mentioned that I did, so to answer your question precisely, yes, we do understand and try to learn what kind of stroke we introduce in our study. So we can have a lack of the blood supply to the brain causing stroke, that is ischemic, a rupture of the blood vessels to your brain, that is hemorrhagic, or a combination of both, or maybe much more complex forms of the stroke. In our study, we had 3 different kinds of stroke that we had introduced in our study. That was ischemic, hemorrhagic, and both. There were a few of the embolic ischemic strokes as well, and we did introduce that in our machine learning model. as I would expect, it did not come out to be the important contributor to understand the within-session learning patterns. But I'm sure if we going forth and look based on the evidence that we have it currently, maybe with the advancement of the more data and more better paradigm to understand the motor learning, we would have more specific answer depending on what type of the stroke and how it particularly impact the learning patterns. So, yes, thank you so much for that question.
I think we need to move on.
Okay, perfect.
Thank you very much. And then our second Dean's Fellow is Steffi Joslin from Human Development and Family Studies.
All right, that really is no joke about those lights. Thank you all so much for having me today. I'm really excited to share with you about my research, which demonstrates that psychosocial adversity is really important for the biological type 2 diabetes risk of adolescent girls. So I am a mental health counselor and have worked with lots of teens that have a mental health diagnosis as well as some sort of chronic condition or disease. And I got really curious about what's going on in their environment and how these things might play together to contribute to this double risk. We can think of diabetes and depression as one of these aspects. So we know that adolescents that have type 2 diabetes, 1 in 5 of them are likely to have elevated depression symptoms. This confers risk for poorer quality of life as well as early mortality, and it really is a big burden for these families. Moreover, we know that these particular adolescents are experiencing a lot of risk in terms of their family or psychosocial experiences. And so I was really curious about how these different factors might play together to confer what I'm calling a constellation of risk. So I'm sure you all have looked at the stars at some point in your life and have seen a constellation of stars at some point. And that's really what I tried to pull together, is a new way of thinking about a hypothesized set of stars or risk factors that might be related to these adolescents' disease or risk for disease. And so my hypothesized constellation involved not only the adolescents' depression, but also their parents' depression. And then I looked at that as it related to their insulin resistance, or how well their body is managing their blood sugars using the hormone insulin, and their stress physiology, how the body is taking on physical stress. And then I wanted to place this in context, so looking at social context or social adversity, things like their racial or ethnic identity, as well as their exposure to adverse childhood experiences, things like abuse or neglect or substance use exposure when they're young. So I was really curious to pull these things together, and then controlling for their age, their body fat, as well as their puberty status, I looked at how they all interacted. And I'll point to the slides at the bottom. You can see that the red and orange lines, and the darker lines, indicate pathways of risk, but that there's also some pathways of resilience that you'll see in green. So we can see in the first plot that at higher levels of adolescent depression, we saw the most insulin resistance, which was worse for these teens. But that was only in the context of teens that didn't have any exposure to adversity in terms of adverse childhood experiences. However, for those teens that were in the high ACEs group or experienced lots of adversity, when both themselves and their parents were more depressed, we saw the poorest or lowest cortisol functioning. But interestingly, even in this high-risk context, we saw that if parent depression was lower, cortisol functioning was better, which was exciting to see. And then additionally, in terms of inflammation as another measure of stress physiology, both adolescent and parent depression were related to higher inflammation or worse inflammation, but only for those teens that exhibited adverse childhood experiences at high levels. Then finally, in the last plot, you'll see in the minority status plot, again, a similar pattern in that when higher levels of parent and adolescent depression were concurrent, we saw the worst or most inflammation for these teens. But again, even when this high-risk context was occurring, identifying as a racial or ethnic minority, as well as being highly depressed, if a parent's depression was lower, then inflammation was better. So taken together, we can really look at these results and see that there's some cumulative or additive risk of psychosocial adversity for these teens, but it's not just a constellation of risk, it's also a constellation of resilience resilience in that if their parents had lower levels of depression, it conferred a potential buffering effect in that it might protect from the biological risk that these teens could experience in these really high-risk contexts. So this is really exciting because it helps us look at how we can better help the health of these teens that are at risk for type 2 diabetes, specifically in the context of their families and their social systems. Thank you so much. I'd be happy to answer any questions. Thank you.
I am just curious when you're talking about the parental depression. I'm thinking, is it in utero? At what age is this occurring? That it has these opposing directions on your graph?
Yeah, that's a really great question. So for this particular study, it was concurrent at the time of measurement with the adolescent's depression, as well as all these biological markers that we took. So that all happened within the same couple weeks. But there is research that prospectively things like prenatal depression might be related to some of these things across the lifespan. So great question, thank you.
Hi, thank you for this, and I love, of course, it's HDFS, so you're supposed to include family, right? But
yeah.
I love it, love it.
Thank
you.
you.
So my question is, how do you hope that that your research and other similar will move to that treating that parent and the child?
Yeah, that's a really good question, something I'm very excited about. So in the research lab that I've been involved in, we do a lot of work looking at how we can treat depression to prevent some of these biological outcomes for teens. I'm really curious about what it might look like to add on potentially even just screening and some information for parents of adolescents that are at risk for type 2 diabetes, if that would even help families, and parents kind of think about their own mental health and seek their own treatment. And then if not, could we look at family interventions like family therapy or parallel interventions? So if we're treating the teen in some way, could we also provide treatment or information to the parent in a parallel fashion? I think it's a really exciting opportunity. Thank you. Thank you.
Excuse me. Thank you so much to each of our speakers for sharing their outstanding work with us today. Let's give them another round of applause. Also, before we have a short break before our next segment, I have a few announcements, so bear with me. We have some exciting news today. I'm pleased to announce that our 2 new Dean's Fellows have been selected for next year. The Dean's Fellowships are $10,000 stipends awarded to PhD students in the college who are selected through a competitive process with proposals reviewed by our college research committee. If you're in the room today, please stand as I say your name. Our first Dean's Fellow is Jill Krause from Human Development and Family Studies. Right. Jill's proposal is entitled Maternal Stress and Mindfulness in Pregnancy, Linking Health Across Generations. Jill is mentored by Dr. Sammy Brown, Rachel Lucas-Thompson, and Stephen Eicheler. Our second Dean's Fellow is Kinsey Matzeller from Food Science and Human Nutrition. Kinsey's proposal is entitled Evaluating How Ultra-Processed Foods and Complementary Feeding Approaches Influence Infant Growth and Adiposity using a Randomized Controlled Feeding Trial. Her mentors are Dr. Minghua Tang, Chris Gentile, Megan Mueller, and Sammy Brown. Please join me in congratulating our 2 new Dean's Fellows. I have one more announcement. Last fall, we held the second annual CHHS Teaching Colloquium. This celebration of teaching excellence was an interactive event where faculty, staff, and graduate students participated in activities to exchange ideas that promote exemplary teaching practices. We enjoyed a keynote address, a panel discussion about the evolving classroom, presentations by last year's Dean's Faculty Teaching Fellows, Dr. Molly Gutierrez and Dr. Julie Taylor-Massey. Participants engaged in interactive innovation stations from teachers across CHHS and our partners at TILT. We are already planning the third annual event and look forward to hearing from this year's Dean's Faculty Teaching Fellows, Rick Perry and Day Halsey. Watch for an upcoming announcement of the fall 2026 Teaching Colloquium date and a call for innovation station proposals. Additionally, the nomination process for next year's Dean's Faculty Teaching Fellows is currently open and will close April 6. Now we will have a short break and reconvene in 5 minutes for our awards ceremony and reception to honor the outstanding presenters at this morning's poster session. Thanks for joining us in celebrating research and creative scholarship in the College of Health and Human Sciences.